We've described increasing emphasis being placed on the need for quality measurement. Let's now take a look at how quality measures are developed, what they look like, and what challenges exist in using the measurements. Quality measurement development is a process that is grounded in research and includes use of many stakeholders to review, approve, test, and endorse measures. Any given quality measurement used in healthcare should undergo the following rigorous steps prior to adoption. 1. Clinical research is conducted that links a process, structure, or outcome with improved health or experience of care. For example, it has been found through research that a beta blocker after heart attack reduces risk of death. This research is extensive, is often performed in multiple settings, and can take many years to make a linkage. Second, when there is a sufficient body of evidence from clinical research of a linkage, stakeholders evaluate that there is a sufficient body of evidence so as to make measurement valid. They will also define parameters for measurement that are at a fairly high level of specificity. These stakeholders are often those from professional societies. For outcomes measures, most will be from medical societies. For structure and process measures, stakeholders will also come from professional associations such as the American Hospital Association, Medical Group Management Association, etc. Third, detailed specifications are then developed that describe what will be measured and how. In addition to healthcare professionals, persons working on detailed specifications may include statisticians and others. As electronic clinical quality measures, ECQMs, have been developed, IT and health information informatics professionals are also involved. Fourth, specifications, once developed, are vetted with key interest groups such as professional societies and consumer groups. Consumer groups include not only those representing patients, but may also represent EHR vendors and end users of the measurement data, such as analytics specialists and others. Fifth, testing is then conducted to ensure measures work as designed. Such testing may use pilot sites who apply new measures under a specific protocol for such testing. Sixth, approval is obtained by the entity charged with development. This entity may be any number of organizational types. Measures placed in repositories will always identify this developer. Finally, endorsement by professional societies, consumer groups, NQF, or government agencies such as CMS may occur but is not necessarily required for use, as once a measurement is published it may be used by anyone. I also want to note that the Agency for Healthcare Research and Quality, or AHRQ, lost its funding in early 2018 for maintaining the National Guideline Clearinghouse. Although AHRQ has observed that there were many sources for obtaining the guidelines, its support contractor, the ECRI Institute, agreed to host it for a subscription service for users, though not submitters. However, it has yet to launch the service as of late 2018. Let's look at a measurement description. When they are placed in a repository, measurement descriptions are cataloged in a manner to make retrieval relatively easy and version control possible. This measurement's title specifies it is a measure for beta blocker therapy in heart failure, specifically directed to left ventricular systolic dysfunction. The measure is NQF endorsed. It includes 11 pages of information. Measurements that are used by CMS, as this one is, often include two formats, one for direct reporting and reporting to a registry, as in the case of this example. Providers reporting this measure send data to a registry, which then compiles the data in a form and format as specified in the measurement specification and forwards the information to CMS. Measurements may also apply to only a certain population of patients. This one is for patients aged 18 years and older with heart failure and current or prior left ventricular ejection fracture of less than 40% who were prescribed beta blocker therapy either within a 12-month period when seen as an outpatient or at each hospital discharge. Reporting instructions specify how often this measurement may be reported. CPT code reporting instructions are also supplied, which would mean that the measure is for physician reporting, not hospital reporting. The specification then goes on to describe denominator reporting and numerator reporting. At the end of the instructions for reporting, there is also information on the rationale for use of this measure, that beta blockers are recommended for patients with stable heart failure unless contraindicated. Information includes that research has shown beta blockers lessen symptoms of heart failure, improve clinical status, reduce future clinical deterioration, and decrease risk of mortality and combined risk of mortality and hospitalization. This measurement also includes some clinical recommendation statements, such as there are 3 beta blockers proven to reduce mortality, including for dosing for persons discharged and for use in the hospital. Also included is the fact that this measurement specification is provided without warranty and was copyrighted by the American College of Cardiology, the American Heart Association, and the American Medical Association. Finally, there are some appendices that describe measure flow in both chart form and narrative form. Well, we've alluded to several challenges in using measures. Some of you may be heavily involved in quality measurement for your organization and be well aware of some of these challenges. Improving quality measurement can have a direct impact on cost and quality. So let's take a look now at some of the burdens and issues of concern as we look at operational needs for value-based care. Everyone wants measures to be reported. Accreditation agencies such as the Joint Commission, NCQA, and many others, including for clinical departments such as labs, pharmacies, etc., want to be assured that organizations who are accredited have measurement processes in place. Professional societies, especially for physicians and certain other advanced practice professionals, use measurements for credentialing their members, again to assure that any special acknowledgement has been given based on factors that include use of quality measurement and presumably with appropriate outcomes. Many providers, as we said before, use registries of many types for a variety of purposes, but not just registries for reporting, but for example, tumor registries, diabetes registries, etc. for research. And then last but not least, virtually all health plans, private, commercial, government, require reporting of measurements, and at least some of the private commercial plans have measurements that are either proprietary or have proprietary variations required of endorsed measures. So not only does everyone want measures to be reported, it seems, but there is too much reporting, too many measures. Some examples. There are 33 different CMS programs that use over 850 unique measures. Every provider setting is impacted. A few examples. Billings Clinic, which is in the Montana, Wyoming, and Dakota areas, report on 102 measures. The Ochsner Health System in Louisiana reports on 213 measures. Private health plans serving New York State were found to use 546 measures. And it is not only the actual reporting that is too numerous, but NQF has endorsed 635 quality measures, and AHRQ's National Guideline Registry in 2011 had over 3,700 guidelines. Although, as we will discuss in the next slide, guidelines are somewhat different than measures, though have certain characteristics that are similar. Finally, on this slide, too much variation and inconsistency may worsen from a clinical may be worse from a clinical perspective than too much reporting and too many measures. For example, measurements relating to use of mammograms include one for women that suggests annual mammograms should be done for women ages 40 to 75. Another measure for mammograms also recommends annual mammograms, but specifies its range as for women 30 to 80 years old. And guidelines newly released from the U.S. Preventative Services Task Force recommends that mammograms be done only every other year and for women between the ages of 50 and 74. As another example, diabetes measurement of the hemoglobin A1C varies between Medicare recommendations for control being considered less than 8%, while HEDIS measurements consider control at less than 9%. Clearly problems in being able to compare measures amongst themselves. Continuing our discussion of today's challenges, another is that too few measures are directly relevant to consumers. This is a complaint expressed by many, although the example commonly cited, that of infection rates, sounds to me like not being very supportive of transparency and something that patients-to-be could find valuable. Also, too many measures are focused on process. For example, timing of medication prior to surgery. This is probably an issue of both relativity, that is, how many process measures are there in relationship to outcomes measures, and relevancy. Many process measurements really are a means to an end. That is, if outcomes are poor, providers should be looking at processes for potential root cause. Unfortunately, it seems that many who require measurements do not trust that providers will look at processes on their own accord. Trustworthiness of measurement requirements themselves can also be called into question, especially when literature, advertisements, colleagues, and other sources may offer conflicting or obfuscating information. AHRQ directed a portion of its research funding to its National Guideline Clearinghouse to evaluate guideline provider submission against the 8 standards required of measurements by the National Academy of Medicine: transparency, management of conflict of interest, development group composition, guideline systemic review intersection, evidence foundations for rating strength of recommendations, articulation of recommendations, external review, and updating. If it found the guidelines don't measure up, they were required to discontinue their inclusion in the clearinghouse. Finally, reporting is time-consuming and costly. Examples from the literature include 12.5 hours of physician and staff time per physician per week are spent on entering information for the sole purpose of quality measure reporting. 785 hours of staff time per year to track metrics is the result. $15.4 billion are spent annually by physician practices to report quality measures. Health systems require, on average, from 50 to 100 full-time staff, including physicians, at a cost ranging from $3.5 million to $12 million per year per health system. Electronic measures, ECQMs, do not exist for all measures, and EHRs do not support all ECQMs. Most process measures require data from administrative information systems that are not always set up to supply such data, resulting in costly manual data entry.